So here's the Pringle, and this is the superior margin. Superior margin has a very close relationship to the edge of the basilar membrane. So we will often ask you to remove the bony overhangs so that you can see the entire Pringle, but we don't want you to injure the basilar membrane. So you have to remove the bony overhang, but do not drill up into where the attachment of the basilar membrane is. The other, the anterior part of it is the part that you see when you're looking through the round window membrane. And you don't see most of the round window membrane when you're looking through the facial recess, because you have your view is to forward, and so you usually see only this portion of it here. The posterior part is in the axial plane, and you never see that because it's hidden, because you're looking forward. The crista fenestra is the area of the inferior anterior round window membrane and defines the bony margin of the scala tympani. So you'll hear us a lot use that term, crista fenestra, because you will remove the crista fenestra when you extend the round window membrane into a cochleoscopy. The inferior round window membrane relates to the cochlear aqueductant vein. And this is very important because if you drill too low, you can injure the cochlear vein of the cochlear aqueduct. And what does that do for hearing? It may be one of the reasons why we lose hearing, is if we drill too low and then we interfere with the blood supply to the cochlea. Now I want to show you just a little bit of histology. You guys are very welcome to these PowerPoints. I think it would be useful if you had them so you could study them at home. And maybe we could, if we have your emails, maybe we could send them. At least mine, I'm perfectly happy to send along. So this is an image, a three-dimensional image of the basal turn of the cochlea. This is the round window membrane. Here's the cochlear aqueductant vein, and the basilar membrane is coming in on top. It almost looks like a little bus, doesn't it? Anyways, this little line is showing the section through the basilar membrane. This is the point of it. So it's going through the posterior edge of it. And here is the round window membrane, and here is the basilar membrane attaching. You see how close it is, a fraction of a millimeter away. So the last place you ever want to drill is back here. Now, this is the anterior margin of the round window membrane, and you can see now scala tympani is forming, and you have some space to put your electrode. But still, the basilar membrane is very close to this bony overhang. So if you drill too superiorly, you will drill into the basilar membrane. And as Dr. Haynes said, even if the patient doesn't have hearing, you want to maintain the structure, the architecture of the cochlea. You don't want to be damaging things that don't need to be damaged, because ultimately it will have an influence on the outcome. And I can't agree more with Dr. Haynes. It used to be that anybody could be the surgeon, it didn't matter. What mattered was the program. But now, the surgery actually matters. And doing it safely and preserving structure does correlate with outcome. Now, here's a couple pictures for you. This is a view of the cochlea from inside the basal turn. So we're looking back to the round window membrane. It's very confusing because you don't usually see this view. But the point I want to make is the basilar membrane is coming in and attaching right to the superior surface of the round window membrane. So this is one bone, and here's another view. This little circle is the opening of the cochlear aqueduct. So if you're too low, opening up this membrane, you will injure that. Look at where the basilar membrane is attaching, right to the superior surface of the round window membrane. Now, for me, this is the most important view. This is the view that I want you to know. This is the view I want you to be able to draw for me. Because I will ask you to draw this. I guarantee it. You know I will. I will come up to you and I say, I want you to draw this. So if you want to take some notes and practice, that's okay. And again, we'll try to give you this. Here is the round window membrane. This is the superior edge. Here is the osseous spiral lamina and the basilar membrane coming in and attaching at the superior surface. Here is scala tympani. That's your target, right? We want to go in scala tympani. Above the basilar membrane is scala vestibula. And then we see the medullus here. These are air cells. It's possible to make a mistake and think you're putting the electrode in the cochlea, but you instead put it into the hypotympanic air cells. So this is a possible mistake. So what I'd like you to do in the lab is after you put your implant in, take it out, and then open up your cochlea so you can study this anatomy. Okay? At the end of this course, I want you to be able to draw the basal turn of the anatomy, the anatomy of the basal turn of the anatomy. The anatomy of the basal turn of the cochlea. Now, so let me ask some questions here. You want to use the pointer? And tell me what you see in this picture. You see that? Show me the round window membrane. So where is the okay. Do you see the pyramidal eminence? Okay. So very good. So the first point is you must make your facial recess big enough so you can have this nice view. Yesterday you saw Dr. Backus, I don't know if you noticed, nice big facial recess. So if you can't see what you're doing, it's very difficult to be a good surgeon. So you need to open a nice big facial recess. That means you must be very close to the facial nerve. You must know where the facial nerve is, pretty much see the facial nerve through thin bone in order to do this well. So I saw many bones yesterday with a very thin external auditory canal. And this is essential for having a nice open facial recess. So that was very beautiful drilling. Nice thin external auditory canal. Now here is the round window membrane. There's the pringle. So where is the basilar membrane in this picture? Exactly. You're exactly right. That's superior edge. So the basilar membrane is attaching right here. So do you want to drill there? No. 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 You do not drill into the basilar membrane. Okay? Okay? This is a common mistake. So where do we drill? We're going to drill inferior and slightly anterior. So down here is where we're going to drill. And that's where the scala tympani is going to open, and that's where it's widest. Okay? Let's see another round window. Are you comfortable to do some laser pointing? What do you just tell us what you see? Round window membrane? Yeah. Tapees? Yeah. Basilar membrane? Yeah. So let me ask you a question. Is this facial recess big enough for you to put the implant in? You got enough room? You see everything you want to see? Yeah, not too bad. Now, the next step is for us to remove these overhangs. So a skill for you to learn is to use a diamond burr. I typically use a 2 millimeter or 1.5 millimeter to remove the bony overhangs so I see the entire Pringle. I don't eat the Pringle. I don't damage the Pringle. I don't break the Pringle. But I drill away the bone so I see the entire Pringle. And what I like to do is to put the burr in the open area and then raise it up a little and pull it back a little and push it forward a little. I like using the equator of the burr. You know, the equator of the burr? And then just come up a little, go forward a little. I want you to practice this so you don't damage the Pringle, but you remove the bony overhangs. So if you start here and move up, it's the safest. If you start here and drill down, you might damage basilar membrane. Okay? So that's just a technical thing for you. Also, I don't know if you remember, but Dr. Backus, he turned his drill down so it wasn't so fast when he was doing this fine drilling. So he slowed the drill down. You don't need to go full speed, 80,000 RPM, to remove this bony overhang. You can slow it down. And I think these drill pedals allow you to turn it down so that you're just grinding it slowly. Okay, now, this is the same ear with the bony overhangs removed. What I'd like you to do is look at your membrane. I want your eyes to go through the membrane. See what's on the other side of the membrane. Everyone just looked at the membrane, but I want you to think deeper. Think what's on the other side of the membrane. And what you can see in many bones is a lighter area that represents the modilus, and a darker area that represents scala tympani. Now, where does the electrode go? Into the modilus or into the scala tympani? Right? So, very common mistake is for you to push the electrode into the basilar membrane. Now, what happens if you push the electrode into the basilar membrane? Or the bony modilus? It deflects. Sometimes it will go into the vestibule. I've seen maybe 3 cases where the surgeon pushed it in, and instead of going down, it went up into the vestibule. And then when they turned it on, the patient had nystagmus, vertigo. It also deflects it and can go through the basilar membrane. You're damaging the cochlea now. So, I want you to look through the membrane and see that you need to go for the dark area. This is what I would call crista fenestra. This is the bony margin. It's like a threshold. You know a threshold in a doorway, you step down, you have to remove that little bit of bone to open up in the scala tympani. Okay? And that's what Dr. Backus did yesterday. He saw the round window membrane and he needed more room. So to make more room, he removed the bone here. It's possible to remove the bone and not disrupt the membrane. This is the highest level of skill. So I will look for this. And if you're able to do it, show me so I can congratulate you. So, now you have to make a choice on how you want to open up into the cochlea. You can use a round window membrane. Just open the round window membrane and put the electrode in. You can do what's called extended round window membrane. That's making the round window membrane bigger by removing the bony margin. So there's no bony separation between the cochleostomy and the round window. Or you can do a separate cochleostomy. That means there's bone between the round window membrane, bone, then cochleostomy. So these are 3 different ways to do it. I think the round window membrane approach is preferred by most surgeons. It's less traumatic. You don't have to drill. You don't have to make a mistake and drill in the wrong place. it's very consistent to enter the scala tympani because the round window membrane leads to scala tympani. So the electrode goes in the right scala almost always, and it's easy and quick. So in America, we like to keep it simple, and we want to get done so we can go enjoy the outside and play some golf. You know, that's what I like to do when I have extra time. So the first question is the electrode you're using suitable for a round window membrane insertion? Some electrodes are suitable, some are not. Okay. The contour advance electrode, which you're all familiar with, and we have, I think, today to use, is not suitable for round window membrane because it's a little bit too big and it has a bend to it that wants to drive you into the medaillus. So for contour advance, you need to do an extended round window or a separate cochleostomy, which is what Dr. Backus did yesterday. The 422, or the slim straight electrode, is suitable for round window membrane. It's a lateral wall electrode that you can just slip in. So we'll have both electrodes today, hopefully, for you to use. If you're going to do a cochleostomy, you want to do it in the inferior and slightly anterior portion of the round window membrane. You see this white area? What is that structure right there? What is this white yellowish area? But not bony medaillus. Thank you. Thank you so much. And then, where is the basilar membrane attached? Up here. What's down here really low? What structure is really low that you can damage if you go too low? Not a trick question. Cochlear aqueduct. Thank you very much. Does everybody know, understand that? The cochlear aqueduct, cochlear vein can be damaged if you go too low. So here's some real surgery. Bloody. See that? Here's our view. Is this good enough to put a cochlear implant in? No. You need a better view. You need to see the entire Pringle. So you need to remove the bony overhang. Now I see the round window membrane. Okay? Now, this is a cochleostomy done inferior and anterior to the round window membrane, which is right here. And then this is a contour advance electrode placed. So you can try both in the lab, and you should, to do both types of cochleostomy. This is probably my favorite thing to do, which is to extend the round window membrane, extended round window membrane insertion. Same place, inferior and a little anterior. Follow the round window membrane into the scala. You will continue to have a membrane exposed in the scala, and it makes this bigger. One of the worst feelings I have is when I go to put my electrode in, and the electrode won't go in because the space is too tight. That's no fun. You know, the electrode is thin at the tip, right? And it's thicker as you come out. It gets it to be almost 0.8 millimeters thick. So you must have enough room. You don't want it to bind and get stuck when you're putting it in. This is very useful when the round window membrane view is unfavorable. Sometimes the round window membrane is hidden or angled, and you can't see it well. But if you see just a margin of it, you just see a margin of it, it's your landmark, and you can just extend it and make it bigger. And it's used when the electrode is not suitable for round window membrane approach, like the contour advance. Okay, some more quizzing. Sorry, I'm so happy you sat in the front row. Just tell me everything you see. And speak louder so all your colleagues know how smart you are. Thank you. Yeah. Where is the basilar membrane going to attach? Where will the basilar membrane attach to this relative to the round of the membrane? Right there, yep. Okay, where should you do your cochleostomy? Yes. Where is the cochlear aqueduct? Ah, good. Very good. A plus. Best possible score. Ah. You okay with this? Okay. Yes? Yes? Where is the basilar membrane attached? Yes? Yes. I'm feeling very good about myself because you guys are getting the questions correct. This is the third one. Overhangs, stapes. You need to remove the overhangs. Remove the overhangs. Now we see it. Basilar membrane attaching up here. Cochleostomy down here. Cochlear aqueduct down here. Here's a bonus question. What other structure sits in the floor down here? We drilled way down here. What other structure will you find? Bonus question. If you drill in the floor of the round window niche, what will you find? Bonus question. No guesses? Huh? What? Vein, yeah, cochlear, the vein in the cochlear aqueduct, yes. I'm thinking about a nerve. What nerve sits down there? Jacobson's nerve. No? Jacobson's nerve is on the promontory. Bonus question. Do you have this condition called benign positional vertigo in Japan? You have that in Japan? So, what operation did we used to do for that before we understood about the free-floating particles? Yes, so the singular nerve. You know the singular nerve? Oh, the singular nerve goes to the ampule of the posterior canal. And if you drill right there, you can reach the singular nerve. A branch of what nerve? Inferior vestibular nerve. Yes, you must know your anatomy. So singular nerve is a branch of the inferior vestibular. Okay, now this is where the rubber meets the road. Where the rubber meets the road. You must draw this anatomy right now. Get out a piece of paper. Use the back of that monogram. I will help you now. This is the view I want imprinted in your brain. You know, my belief is to be a good surgeon, you must know the anatomy. Anatomy, knowledge of anatomy is destiny. It's what's going to make you a great surgeon or not. If you do not know the anatomy, you cannot be a great surgeon. And I know that you all want to be great surgeons. So you must know the anatomy. And to be a great surgeon and know the anatomy, you then apply it. So when I look at the basal turn of the cochlea, I don't see a surface. I see the entire anatomy. I see the basilar membrane. I see the hair cells. And I want you to do the same. I want you to see the anatomy. And then you won't be surprised. Because as you work through the bone, it will be exactly what you expected. Because you knew the facial nerve was right there. So it's not a surprise that the facial nerve is there, because you knew it was there. Enough philosophy for the day, huh?